Thank you. So this will be a little different than most of the presentations today. This is all about process. Process is extremely important. It's basically measurement. I was at Rancho Los Amigos for 30 years. I ran 4 services, a stroke service. No, I'm not a neurologist. I'm an orthopedic surgeon. I ran the brain trauma service, the first categorical disease in the United States, created in '71. I'm not a neurosurgeon. I ran the spinal cord injury service. I'm not a spine surgeon. So you have to have a certain skill in management, sharing metrics to run a program. At that time, I had residents. It was very easy to run residents because they have to take orders from the staff. Once I began to manage physicians in our private hospital, it became a much more difficult problem. The best thing that happened, though, is the way we can measure metrics now through software packages. Before, we just did outcome research, and then we would modify our protocols. Now we're able to actually measure things with our software. So that changes the game completely. So this talk really, the morning part is the keynote part is going to be on measurement, and then I'll actually show you how you manage and share the metrics to do a paper and to run a service. Measurement now within most hospitals is through a process, and by process I mean you have clinical practice guidelines, and then we have such skip measures. And the skip measures, for example, really is a process. It's not an outcome study. So the skip only measures whether we start the antibiotic an hour before surgery and we continue it for 24 hours. That's not an outcome study. That's a process study. It does improve quality assurance, but it doesn't produce outcomes. So what's available in most hospitals is really not effective at managing a service line. So in order to do that, you must think more about outcome studies. The government has already switched to outcome studies in orthopedics. Now for Medicare, we're going to bundling payments. In order to have a good service line, you need to have outcome studies, because if you have poor outcomes, you're going to be penalized in that bundled payment. So the first thing you have to ask, what's lacking in hospitals for you to do a service line? What kind of metrics are available in the hospital? And what are you going to do when you have the metrics? And most of the time, there's not a good answer for any of these 3 questions. And you can't just buy a software package. You'll hear me discuss Marshall Steele, who's been purchased by Stryker. Marshall Steele is local to this area. He created the package that we used. My disclosure is I don't have any stock in the old Marshall Steele or in Stryker or actually any orthopedic company. You can't go out and just purchase the software, whatever software it is. You have to have a service line. So you can't obtain data and then think that you're going to run a service. So you have to have people. I'm really keen on empowered physicians. We've lost our power. We need good leadership. We never talk about leadership in medicine in any of our classes. And then you have to have your nursing, all the allied health staff, perhaps pharmacy, and the patient is always at the center. Now, when you align the incentives and specialize in teamwork, all these people become empowered. So if we just take the physical therapist, for example, our physical therapist used to be assigned to the whole hospital. At 1 o'clock, he may be on the neurosurgical floor. At 2 o'clock, he may be on the general surgical floor. At 3 o'clock, finally, he came to the orthopedic floor. We wanted him there at 8 o'clock in the morning so he could walk the total hip patient and send the hip patient home. So unless they're aligned with your incentive, they're aligned with their own department, and they're not going to do a good job. So you have to have some structure in order to boost performance. So you have to have written goals from your specific allied health professionals. So we have what we call a PIP meeting, which is a performance improvement team, and we meet once a month. And it's actually good if each team member were to write down goals, expectations of what they are going to bring to the service. And they have then certain responsibilities, and they will also have a process form of some sort. If they don't, then the medical director should make a process type structure for them. Everything is based on a protocol, and each individual will magnify their talent whenever you have a service line. Once again, if they're doing general hospital work, they're not very committed, but once you have a person on a service line, they become very committed. If they aren't, then they should be replaced. You always talk about efficiency and effectiveness, an effective leader, an effective team, an efficient team, efficient leader. This entails many people. You need the primary care support from the physicians that are referring to you, because they still want to get in the way of the service line. They want to transfuse when you don't want to transfuse. You have to have efficient operating room through the entire gamut. And you have some results and outcomes available to you, but most of the time they're not going to be the ones that are important. The clinical are hugely important. Financial becomes important. It's not so important immediately, but as you become more efficient, financial becomes very efficient. Operational is the same. Then when you have your reported outcomes, then you can finally manage the process, and you will self-improve as you have your outcomes available. So if you have a 30% transfusion rate, now you can set up appropriate protocols to try and reduce those transfusions. So the management then will come from the metrics. You can't manage if you don't measure it. So you have to ask yourself, if you want to set up a service line, if you want to run a service line, do you have any of this data available at your fingertips? Once you have the data, what will you do with it, and how are you going to improve? So it really does take a village. Once you make a commitment, it's not just purchasing the software. And the financial and clinical success is tied to effective management. So first you have to obtain the data, and then you have to have effective management in order to change the process. When you purchase any software, you have to decide what you want out of that software. One hospital will be different from the other. There are many available out there. So you have to choose what metrics you're interested in. They need to be easy to understand. You need to be able to drill down to specific details in order to improve, because different people will want different looks at it. You have to be able to analyze it in multiple ways. And of course, it's benchmark against best practice. Then you can take your action and report to whoever your stakeholders are, which will be the hospital, the physicians. Actually, we do a lot to the patients, and then to your payers. Now, this is the 5 key ones that is on the Marshall Steel. The clinical is hugely important to the physician. Discharge rates, complication rates, blood transfusions, readmissions. For total knees, it's flexion extension and how much they walk. Every patient walks the day of surgery, or at least that is our goal. We like some sort of regional anesthesia. They walk the day of surgery. Somebody like myself, I like to discharge them if possible the day of surgery. The operating room in many hospitals is always the bane of the orthopedic surgeon or any surgeon. We have lean at our hospital. Even with our care line and our lean, we've had the least correction of our outcomes within the operating room. Mayo Clinic actually published on using a lean and had improvement in their operating room, but of our 5 groups here, we've had the most difficulty still changing our operating room. We have 24 operating rooms, so it's all very dependent on the size of your facility. Operational is hugely important now. Volume is very important, 1 to the hospital and 2 to the individual itself. CMS already in America now for 2018, or not for volume yet, but in 18, they're actually going to patient satisfaction. But in 3 centers in America now, 1 here, Johns Hopkins, Dartmouth, and the University of Michigan, have all said that for high-risk patients and surgeries, that only high-volume surgeons and high-volume hospitals will do that surgery. So you need to know your volume going forward. Length of stay eventually becomes very important for bundled payments, which we're going to in America, and also the discharge disposition, which is a huge component of the bundled payment system. My personal disposition in my total joints is 98% go home. So what's been most difficult to manage in the Medicare population is the post-discharge situation. So this part of the operational outcomes are hugely important. We do have our hospital person, management person in our PIT team, but we never worry too much about the financial. It happens that as you improve your efficiency, the finances improve. That becomes hugely important, which when I go into the actual management, will show you how that works. And then satisfaction, CMS now in 2018, the patient satisfaction is going to be part of the reimbursement. So patient satisfaction is hugely important. And then most of the types have some sort of dashboard. The dashboard gives you a quick overview. It's very easy to understand. And then you have the ability to drill down and to get very specific. So this is our blood transfusion. This is the Marshall Steel average. So the nice thing, you need a benchmark. So it doesn't do you any good to say we have 20% transfusion rates in our total joints. What does that mean? You need a benchmark to compare it to. In the Marshall Steel system, there are 250 hospitals. So their transfusion rate is 11%. I happen to like community-based studies as opposed to so many studies which come out of the university, so that across the country in Marshall Steel, the transfusion rate's 10%. This is our transfusion rate in our facility, and you can see in 2012 it was 10%. By the end, we had decreased it 5% more, And then as we go forward into 13, we continue to decrease it. We also have a green line. The green line is what we wish to be, or our goal, which is 5%. So you set that yourself. So when we first started, our overall transfusion rate was above 30. So of course, the first year, we put it down to 20%. As we continually improve, then we continue to lower the bar or higher the bar, however you look at it. And it's not on this slide, but Marshall Steele has a fourth line, and that's the top performer within the Marshall Steele system. So he actually has one performer. They probably do 10 total joints a year, and they don't do any transfusions. And I'm just kidding. You have to compare a facility like ours, which is 500 to 1,000 total joints. Of course, we're going to have a few transfusions. If we look individually, such as even myself, there are some quarters where I don't have any transfusions. So this allows you to compare to facilities your size as well as individual doctors. And once again, there's 80 different ways you can analyze the material within the Marshall Steele system, so you do want to have that capability. And where does all this go once you're all done? Well, we think, at least in America and to the insurance companies, we're going to be promoting top hospitals. We're going to be promoting top physicians. Hospitals don't want to lose money, so they're now going to be put at risk for complications. This will tie in your networks within a hospital facility. There's around 6 hospitals in our group, for example, and perhaps the low volume people will have to refer to our facility. Puts the providers at risk, so having this data and outcome allows you to know where you stand for future reimbursement results. And once again, I've mentioned bundled payments, but we are now doing bundled payments in our facility. We've been doing the Marshall Steele system for 7 years now, so when the hospital signed us up for bundled payments, it was no problem because we already knew what our complication rates, our readmission rates. It was very easy for our hospital to make a decision to go with bundled payments. So that's what you can do with the data. You also can send the data to your primary care, your referral pattern, so that they have an idea of what you're doing. Everybody wants to be, I think in Southern California, where I'm from, almost every center is a stroke center. And every center is not a stroke center, but every center says they're a stroke center. The total joint service is very similar. It's a very popular thing to be a joint center. This actually allows you then to put your data on paper and send flyers out to the referring physicians so that they really know you are a center. We also like to do a lot of advertising and put our data out in the papers so that we show people what our outcomes are. And also you can just make simple handouts for your office so that when people come in, it builds confidence for the people themselves to see that you are a sophisticated surgeon and have very few poor outcomes. So this is just the management part. So the first part will be the management and thinking software and doing the outcomes. And then when I come back in a couple more lectures, I'll show you how the service was set up. And then I'll do the paper, which is in your handouts, of how we actually applied that data and how you can really improve your service. Thank you. Any questions?